Good morning. I'm Ann Godlasky, president of the National Press Foundation, dedicated to providing free training for journalists in the United States and around the world. I'm joining you today from the Evelyn Y. Davis studio in Washington, D.C., and this online briefing is sponsored by the COVID-19 Vaccine Education and Equity Project, which is a partnership of more than 250 organizations representing patients, caregivers, diverse communities, healthcare workers, and scientists to provide information about COVID-19 vaccines and treatments in a way that promotes equity and trust. This is our second webinar sponsored by the COVID-19 Vaccine Education and Equity Project, and we're thrilled to have a number of esteemed panelists with us here today to talk about COVID antivirals specifically. I'll start with Dr. Jacinda Abdul-Mutakabir. She is the infectious diseases pharmacist and assistant professor of clinical pharmacy at UC San Diego. Dr. Artie Barnes is infectious diseases physician and chief medical officer at the Illinois Department of Public Health. Dr. Megan Panini is chief vaccines and therapeutics officer at ASPR, the Administration for Strategic Preparedness and Response at the Department of Health and Human Services. And Alexander Tin joins us as a reporter from CBS News covering federal public health agencies, and he's been covering COVID since the beginning. So I'll kick off first with you, Artie, if you don't mind. Could you just give us a lay of the land? Where are we with COVID infections now? And particularly, how do we know?
So right now, I hope everyone can hear me okay. We are really seeing a significant amount, what we define as the winter peak of COVID infections. Reassuringly, it is not as high as some of our previous winter peaks, but that doesn't mean that our hospital systems are not under strain, because sometimes what that reflects is not just COVID, but flu and RSV hitting the health systems at the same time. So right now, the overall hospitalization rate for the nation is about 5.8. About the same time last year, it was over twice, about 10.1 per 100,000 people. So how do we know where we are? This question has become a little more complex in these past few months, because we now don't have as much robust case data, but we are focusing not just on who has COVID, but what is really COVID doing to them in terms of severe illness, getting to the hospital, and potentially, not making it out or dying from COVID. And so we are able to get that data fairly accurately, thankfully to a lot of surveillance systems that are in place. We look at wastewater monitoring. That doesn't necessarily tell us how many people are in the hospital, but it helps us look at trends too. And for just those who might not be aware, there are still in place some states that report all the positive tests from commercial labs that they get for COVID. So between all of those, we're able to put together a fairly decent picture of what's going on with COVID in the nation right now.
Thank you. And Dr. Abdul-Mutakabir, a recent NIH study of 1 million high-risk people with COVID found that only about 15% who were eligible for Paxlovid were actually getting it. Why are we seeing this discrepancy?
I think the biggest thing that we have to think about is just the lack of awareness pertaining to the antivirals. I think that, there was a ton of attention put towards the vaccines, and there continues to be. But once someone actually gets infected, I think that education or continued information, presently it kind of stops there. As someone that actually serves high-risk patients or patients that are more likely to fall in that high-risk category, so racially and ethnically minoritized individuals, I would go and present about the respiratory diseases just to create awareness for the season. And it would be blank faces when I would bring up Paxlovid. It would be a complete lack of folks even knowing that it exists, that you can have an antiviral, that you can have something that can help treat COVID should you be infected even after being vaccinated. So I think that's the biggest place for us to start is actually How are we promoting this? Do we have awareness pertaining to these antivirals? Is there another way that we can ensure that this information is disseminated? And then also we have to consider that Paxlovid isn't the only antiviral that folks can get. So we have molnupiravir or Lagevrio, and then we have remdesivir. So we have those individuals that, although they are high risk, they may fall in that category of not being able to receive Paxlovid. Maybe they take other medications that would interact with it. So, I mean, when we think about those patients that live in long-term care, so they may be receiving the molnupiravir, which is why we don't see them receiving the Paxlovid. And then with the remdesivir, we may have people that go to the emergency department, say that they present in that way, and then you run into that issue, right, of those interactions, and then those individuals then don't receive the Paxlovid, they may receive the remdesivir or another treatment option. So I think that's something to consider too, the fact that we do have alternatives, which may kind of take away from what we're seeing with Paxlovid. But I think that the overall issue is that we need to just have increased awareness about the fact that these antivirals exist and they are available for consumption.
And before we move on, I wonder if we just step back a minute. How do these antivirals work, and why is Paxlovid the one that we hear about so much?
Right. So the way that these antivirals work is a bit different than the vaccines. Of course, the vaccines present the pathogen or the virus to you through various formats, and then your body builds immunity. Well, what these drugs do is they actually prevent the virus from being able to go from cell to cell to cell. So it cleaves or actually stops the virus in its tracks. So that's what we see with this antiviral. And that's the difference there between the vaccines. And that's also a place for education, right? It doesn't provide immunity. What it does is it prevents the virus from being able to become worse, essentially. And that's the education that I provide. So why is it that we saw with why is it that we use Paxlovid the most, or why is it that maybe we see a difference in the EUAs? Well, when those initial evaluations came out and we tested these antivirals, what we saw was that, Paxlovid had upwards of an 80%. What we saw was that in at least like COVID progressing. So we saw a upwards of 80% decrease in just that progression, or folks that ended up needing to be hospitalized when they were infected with COVID-19 after they received the Paxlovid. Well, we didn't necessarily see that same reduction in hospitalization rates with Lagevrio. So then when it came time to present which one do you use first, or which one do we provide preference to, then that Paxlovid is where that preference lied. So now those EUAs, which are really exact, and we have to follow those EUAs accordingly. Paxlovid has really been positioned as that antiviral of choice, and then Lagevrio and remdesivir in the EUAs is really those options that you consider if the patient cannot receive Paxlovid. So that's essentially why we see Paxlovid being placed at that forefront.
Thanks very much. And before we move on, I meant to mention at the beginning, for those who are joining us, please feel free. We are going to be taking your questions as well. So please feel free to enter those into the chat, into the Q&A, and we will get to those. And I know that we have journalists joining us from all over, as well as members of the public. So please feel free to submit your own questions, and we will address those with the panelists. I'd like to move on to Dr. Panini now. We talked before about how, the emergency, officially ended, which changed how COVID was being tracked. And, like the vaccines, the oral antiviral treatments have transitioned now from being a government-funded program to kind of a commercial market, a more traditional distribution. What does this mean for patients? What are people seeing out in the real world? What should they be seeing? What does this mean for coverage?
Right. Thank you. And I just want to, reinforce a couple of things that were already said. We know cases are high right now. We know, we heard that from Dr. Barnes. We know also, right, that patients aren't accessing these products as much as they should. And there are different reasons for that. And one is, of course, education and awareness, as was mentioned. We want to make sure in this critical time period, while we still are in this winter surge of COVID-19 cases, that there remains access to the treatments that are so critical. Of course, as was mentioned, Paxlovid is the go-to option. It is approved. Actually, it's both under emergency use authorization, but also has a full approval from the FDA for ages 18 and above. And we do have, even though the product has transitioned from, full USG distribution, meaning we have been distributing for the past almost 3 years, I guess, therapeutics as a sole distributor, completely for free for anyone. As you mentioned, we are now transitioned to commercial market. But for Paxlovid in particular, we still are leveraging the supply that we have procured as USG, as US government, to support continued access to a broad, to everyone, to be honest, right? In these joint programs that are being operated by Pfizer, the manufacturer of Paxlovid. So there are two programs that I want to mention, right? There's a blanket umbrella term for how you can access Paxlovid as we move forward, and it's called PAXCESS. And we can certainly share the link, but really want to make sure that everyone understands that this program exists. One arm of that program is what we call the Patient Assistance Program, which is for anyone who has public insurance. That means anyone who has Medicare, whether you have Part D or don't have Part D, which is usually how you get your drug benefits, of course. It doesn't matter. Anyone that has Medicare coverage in any way is covered by this program. Any Medicaid individual, anyone who's covered by Medicaid has access to this program. Anyone who is uninsured also has access to this program. And all you need to do is enroll. It's a very, very easy process. It can be done by the patient. It can be done by a caregiver of the patient. It can be done by the patient's physician. It can be done, the pharmacist at the counter can guide the patient through it because it is very quick. It can be done online. It can be done over the phone. It's about 5 minutes. And really minimal information, right? And again, that means you would get absolutely free product. You would get no cost to the patient, neither for the dispensing fee or the actual drug. You get it at zero cost through that part of the PAXCESS program. The second part of the PAXCESS program is for those who have commercial insurance. And that is fully operated by Pfizer. So we are not using our USG product to support that arm of the program, but that is a Pfizer program. And that actually does buy down any copays that are associated with your commercial insurance. So again, bottom line is no one should be paying full price for Paxlovid. There are programs in place to ensure that unless they choose to, right? If somebody wants to pay, of course they can. If they don't want to enroll or they don't want to leverage these programs, they can. But we really want to emphasize that the best way to make sure, especially as everybody's getting educated and, things are ramping up, the best way to ensure that you really get the best no cost or very low cost Paxlovid is that you enroll ahead of time, right? You go to the webpage, you'll be directed to which program is right for you, and you walk into the pharmacy, with the paperwork that says, this is the program I fall under, and this is how I get my product. So, of course, it can also happen at the pharmacy counter, right, where things are ramping up and, payers and pharmacies are getting all on board. But again, the best way to just ensure, especially in this time period, is to take that initiative for your patient. We want providers to be aware of that. We want the public to be aware of that. We want the pharmacies, everybody, right, across the board to be aware of that program. So again, to be very clear, no one needs to pay full price for Paxlovid. Real quick, we'll mention Lagevrio, molnupiravir, right? There's also a program that exists there called Merck Helps. And that program is specifically for patients who could not otherwise afford the medication. So that one is a little bit more restricted, if you will, based on an income assessment. But and then there's also, I think, additional programs. We have less insight into the Merck programs because we are not as involved because we do not, have a continued contractual relationship with them. But regardless, we are hearing there are also copay type assistant programs to buy down copays for those who may be commercially insured or for individuals who may not meet the income requirements of that Merck Helps program. So I know that was a lot of information, but bottom line, really just want to make sure if you're hearing, that somebody is paying full price or is told that they need to pay full price for Paxlovid, dig a little deeper, because that's not the case. That should not be the case.
So Alex, in your reporting, what have you been coming across lately?
Yeah, well, I mean, a lot of it comes off of what Dr. Panini was just talking about, this question of how the patient journey of how patients in the United States are accessing Paxlovid is a lot different than it was a couple months ago because of this change to the commercialization of the product. The patient journey, as Dr. Panini laid out, makes sense, right? You want a patient who is in this eligible category. Let's say it's, a senior who is enrolled in Medicare, right? To go enroll in this website, go to the pharmacy, get their Paxlovid for free, and then take it, within that 5-day window that they need to. But there are a lot of points along that journey that, because it's now commercialized, because it now relies on this program, that it can really get difficult. A lot of providers, you just heard Dr. Panini talk about it, don't really know that this program exists. So when they're prescribing it to their patients, they don't know to tell their patient, hey, if you're Medicare, if you're Medicaid, if you are uninsured, you need to go to this website to sign up or call this number, right? You also heard a lot of issues when patients were going to the pharmacy, Medicare, for example, as an example. They would go to the pharmacy to pick up their prescription, and they're told by the pharmacist, hey, I'm getting this weird issue with your Part D plan. It looks like they aren't fully covering it. You can pay a couple $100s, or maybe you can go to another pharmacy. And they don't tell the patient that, hey, there's this way that you're supposed to get the pills for free. So again, those are just some examples where that journey can fall apart now because there just isn't a lot of awareness among some people that this program exists. But aside from that, we also know that there are all kinds of other issues happening in this space of treatments for COVID-19. We know that there are other treatments in the pipeline, especially for those populations that maybe can't quite benefit as much from Pfizer's Paxlovid. Immunocompromised Americans, they used to use a product called Evusheld that was manufactured by AstraZeneca that essentially offered them protection for those people who can't get protection from vaccines. But Evusheld was pulled from the market because variants would dodge its protection. And then there really hasn't been a replacement since then. AstraZeneca is working on its own replacement that people thought might get approval by the end of last year, but it didn't get that FDA authorization. There are other companies that are also working in this space. But again, Paxlovid is important, but it's also not the only tool in the toolbox. And as these new variants have been coming, we have seen more and more of those tools either get weaker or go away.
Okay.
And if I could just add something, if you don't mind, just
Sure.
back to the point of the patient journey, and we appreciate, right, that we want to make this as seamless as possible. We also, want to make sure that there's broad access. And so that's why we set up these programs. But just to be clear, it should work at the counter. That's the goal. We're trying to make sure that gets implemented so it's a seamless process for the patient. But again, especially in this time of transition, it's good to take the initiative when you can, and do that enrollment ahead of time. But I just, I know I don't want to belittle the efforts, monumental efforts that our pharmacy team and payer teams are doing to make this a seamless process sort of on the back end so patients don't even notice.
We did actually have a question come in that I'll read to you guys now. It was an anonymous person who asked, what is PAXCESS link and how do you spell it? And other links for other programs. Thank you. Someone else asked, what are the names of the 3 other alternatives to Paxlovid?
Yeah, I don't. Do you want us to answer those?
Yeah, whatever one you'd like to answer.
Yeah, sure. So the alternatives to Paxlovid are remdesivir, which is also Veklury. That is the trade name of Veklury, which can be used, of course, in hospitalized patient, but also is appropriate for outpatient use. It is an IV infusion, though, that occurs over 3 days. So it is a difficult product to administer to patients, but that is available, and that is also an approved product. And then the other alternative to either Paxlovid or remdesivir would be Lagevrio, which is molnupiravir. And that one is still under EUA. So that is one that has to be used strictly under the EUA authorization, and only used as an alternative when Paxlovid or remdesivir are not clinically appropriate or are not accessible for that individual patient.
I'll be typing those in the chat as well to allow for folks to be able to find them.
Thank you, Jacinda. And we've mentioned EUA a couple times now. Does someone want to jump in and explain, just for folks who aren't familiar with that, what that's all about? Dr. Panini, perhaps?
Yeah, sure. I'm happy to do that. Don't want to eat up too much of the airtime, but I do think that one is squarely in my zone. So EUA is emergency use authorization. So this is an alternative pathway for FDA to authorize a product in a time when a particular fast track, if you will, to authorization is needed, versus a full approval, which of course can take a much longer period of time. So, COVID-19 is not the first time that the EUA mechanism was used to get products out into the market. As soon as, FDA has said, always FDA does a fantastic job of ensuring safety and ensuring efficacy. But this is a mechanism that allows them to get needed products out into the field a little bit quicker than they can with a full approval process. That being said, right, the EUAs are always intended to then progress to full approval, and we've seen that happen with the vaccines in some cases, and also have seen that happen now with Paxlovid for 18 and above, and for remdesivir, which is fully approved for all ages.
Thank you. And I was going to ask, and apologies if this was already covered, but with PAXCESS, what are you seeing in terms of enrollment? Is the participation where you would like it to be?
Yeah, so I can say it's still in early days. What I didn't get a chance to mention, and thank you for the opportunity, is there still is a lot of fully free USG distributed product out there sitting in pharmacies. And so, it will take a little bit of time. It's millions of patient courses. So it will take time for that to get used up. Which is great, right? You can still find places where you can get absolutely free, no enrollment, nothing, product. And so until that really is drawn down, we won't start to see these other programs being leveraged as heavily. But I will say, we know that it's being used now. It's really but not to the full extent, because obviously there's still this EUA product, and people are being advised to use that up first, and then transition to the commercial product, which then you have to start leveraging these programs. So we know it works, but it's not getting used in high volumes as expected, because we're still using that fully free USG distributed product.
Thank you. And Alex, I wonder if we can go to you now. What are you like for you? You've been covering this topic for 3 years in obviously a very intense way, as many journalists have been. What do you think are still sort of the uncovered or undercovered stories about COVID right now?
Yeah, well, I think one of them that we just talked about is these details of maybe, I shouldn't say fringe cases, but these less common cases of patients who either catch COVID or want to avoid catching COVID. And for whatever reason, the tools that they need to do that are harder to get now, especially as, the public health emergency has gone away, as these products have gone to the commercial market. And you see this, you saw this with antivirals, you saw this with the vaccines too. There was the CDC's Bridge Access program that they rolled out to kind of plug the holes for those more vulnerable communities that need vaccine. But then you would look to places like long-term care, and the vaccination rates in long-term care for people where the pathway to getting a paid vaccine for them should be easy and should be straightforward. The rates, you've heard federal officials say, is way below what it should be. So that's something that obviously has been covered a little bit, can't be covered enough. Another thing that is going to be interesting as we, progress through these coming months, and is something that I think is going to need to be covered more and more, is all of those remnants of the public health emergency, how those are going to be unwound at the local, state, and federal level. We're talking about regulations and products and routines and guidance and benchmarks for when, hospitals implement masking, for example. You saw this wave of stories over the past couple of weeks as places moved into that kind of yellow zone on the CDC's map for COVID-19, that they would start implementing masking in healthcare facilities and nursing homes. But then we don't have that same kind of official benchmark for flu or for RSV or for that combined metric. Some local places have implemented their kind of own way of measuring that. The CDC does have a combined way to measure that, but that isn't directly translated into guidance. So, there are all of these ways in which, even though the public health emergency ended last year, there's still so many parts of the public health infrastructure that still need to be kind of moved back into that peacetime world and essentially updated to include this whole new pathogen.
Thank you. And where are you seeing reader interest right now in terms of stories related to COVID?
Well, I am not the SEO guy, so I don't have the numbers in front of me, but I know that a story that is always very popular with their readers, especially at this time of year, perhaps unfortunately, is the variants. It feels like there's this infinite alphabet soup of variants that keep coming along, and people start mixing up the names. The new one is JN.1, which is the descendant of BA.2.86, which is technically a descendant of the Omicron variant, but it has so many mutations apart from it that a lot of scientists think it should be just considered as separate from the Omicron variant. JN.1 is obviously sparking a lot of interest because it's increasing nationwide. There are all these questions of whether or not it's going to have changes to severity and symptoms and the protection offered by vaccines. What we've heard from the federal government is essentially there isn't a cause for alarm. It's the same thing you're hearing from international health authorities that, we aren't seeing that increased severity. We aren't seeing suddenly vaccines losing all of their effectiveness. We aren't seeing all of our tests stop working. But that doesn't mean that people aren't curious about, how is this variant driving all of these new cases? How is it changing the way the virus is spreading through our population? And is this a sign of something we might start seeing every year, these new highly mutated variants, or maybe not? So variants is something that is obviously probably going to continue to be of interest for our readers, especially every time we get this kind of new increase around the winter.
Absolutely. Thank you. And a reminder to the journalists who are tuning in, please feel free to submit your own questions and we will get those answered for you. I'd now like to go to Jacinda or Artie. I wonder if we could talk about what you're seeing in terms of disparities in access. I know that I've seen maps of, where antivirals are being prescribed and taken and where they're not, and they sort of follow those, we're seeing it like higher uptake in the Northeast, less in rural and southern areas. And I wonder if you both might want to take a stab at addressing that.
I can start if you want, Artie, and you pick it up, or vice versa, whichever's best. Okay, sounds good. So I think, for me, one thing I will say is, we continue to see disparities with the therapeutics as well as with the vaccinations. And I think that, both Alex and Dr. Panini really honed in on why we see this. Well, when things go commercial, when things begin to cost money, as soon as we saw that the end anyway of that public health emergency, and when everything was paid for, I immediately lost my vaccinated partner. like not when I say lost them, like they ghosted me. And I work primarily in a minoritized community. So, I worked for 3 or 4 months to try to get enrolled in the Bridge Access program. It was very hard, very complex. It was not an easy process to become enrolled in there. I'm honestly sad to report that I never was able to complete the enrollment, was never able to finish the Bridge Access. Thankfully, through honestly, it was on my knees begging the San Bernardino County Department of Public Health was able to partner with me and bring vaccines to the several different events that I had in San Bernardino County. So we were able to vaccinate, but it took me 6 months to identify a vaccinating partner. And the most interesting thing is, when you think about racially and ethnically minoritized communities, when you think about, the Black population in particular, what people would have you think is that these individuals are hesitant, that they do not want vaccinations. But I had 50 people who were ready to receive COVID-19 vaccines, but they had no idea where to get them. They did not have money to pay for them. They did not know about bridge access. And I did not have them because at that time I had not been able to partner with the San Bernardino Department of Public Health to bring the vaccines into the community. So, I mean, think about that in the context of therapeutics that no one even knows exist. So, I mean, I think, that's definitely the issue. When that emergency order went away, a lot of resources that we had went away, a lot of resources that were being allocated to those providers that were in the communities providing education went away. Most of the things that I do, there is completely free. I go into the community at no cost to them because it's me wanting to bridge that gap. But I mean, when you don't have those people that are willing to bring in those resources, we're definitely going to see disparities. I think we can trace this back to the start of the pandemic. We saw that Black individuals, Hispanic individuals, American Indian, Native Americans were 30% less likely to receive a prescription for Paxlovid in comparison to their non-minoritized counterparts. So, I mean, that's something that we continue to see perpetuated. When we think about even when these newer geospatial studies that are looking at disparities of the COVID-19 test to treat programs, they've been implemented since like 2022. Well, we continue to see that people that live in rural conditions are upwards of 30% less likely to be offered a prescription. They are further than 20 miles out of being able to go to a pharmacy and ask for this. They're unaware of the fact that you have to do this within the 5-day plan. So, within a 5-day time period, I had someone come up to me and they say, you know what, when you told me about Paxlovid, I immediately went because they had been feeling sick. They essentially went to get tested. But they were outside of that time window. And then they were unable to go ahead and receive the Paxlovid, but they were like, well, I tested at home and it was a weird positive. I likely could have gotten it had I taken that at-home test. And I was like, you absolutely can take the at-home test in with you. Had no idea about that. So I think, that education disparity continues to permeate through these different areas of COVID. But more importantly, when we think about that emergency order, we don't really think about how much protection it provided. We don't think about how much, the pandemic, and I just cannot stress this enough. It looks completely different right now. The way that we're able to give people these really useful medications looks completely different right now. So, I mean, the disparities are abhorrent, if I have to be honest.
Thank you. Artie, do you have anything to add to that?
Yeah, I think one way we're trying to look at it, and again, it's a really unfortunate commentary on a society. These disparities preceded the commercialization, as Dr. Abdul Kabir said. Even when during the time of monoclonals, African Americans and Latinx were about almost 50% less likely to have received it. So there are some inexplicable differences that are not justified by, say, just financial access. And so what we've also done, and I think I really appreciate the federal government with helping states as a whole look at something called the EDI, or Equity Distribution Index. We're able to pull information on the providers in our jurisdiction that actually have, this was pre-commercialization, that have been giving prescriptions, and what the rates of prescriptions are, and even providers are in high equity distribution index, EDI zones. High EDI is not good. It's actually bad. It means you're more socially vulnerable. It's a replacement of the SVI, a social vulnerability index. And so systemically, we're seeing that there are lower per capita prescriptions in providers who are more from providers and who are in the more vulnerable areas, in spite of a higher hospitalization rates in those areas. So there's, a lot of work to be done. Again, this is where the media can come into play instead of focusing as much on rebound. And some of those concerning messages can really affect populations that have historic mistrust of the health system far more than others, which, so focusing more on the fact that there is a disparity in the death rates. There's a disparity in the hospitalization rates driven by both lower vaccine, lower treatment, and we're not as much focusing on that message that these treatments work, even though they're not perfect. They actually are powerful in protecting you from getting that. And so some of our outreach, at least in our jurisdiction, to disadvantaged communities and to ethnic minority communities have also been challenging because it's harder to get a trusted messenger within those communities. The government is not it anymore, unfortunately, as a trusted messenger. So whatever the media could do to really level the balance of inequity, that would be really important, I think, right now.
Thank you. And you mentioned rebound. I wonder if you could talk a little bit about, because I mean, whenever I've brought up antivirals with, family or other lay people like myself, that is kind of the thing that I hear about. I wonder if you could talk about the science, the research. What does it actually show in terms of rebound? In terms of, is that something that is a huge risk with this, or is it not? Is it more anecdotal?
So it's not just about the risk, but it's about the impact of rebound. So rebound just means that you had the infection, it went through your system, and now it's resurging. We see that with a lot of other infections, by the way, not just COVID. With COVID, of course, with COVID on our minds, it became a point of awareness for the world as a whole. But what it means is you might be non-infectious for a period of time, and then the virus gets reactivated because it hasn't been fully eliminated from your system. And then you might be infectious again. Your symptoms might recur. You might feel a little sick, but the overarching message is that even if rebound occurs, it's not more likely to get you to the hospital than having that initial infection. It also is important to remember rebound occurs not as frequently, even those who haven't touched antivirals. So while it is associated with antivirals, there's something going on in our bodies. As I said, rebound is and recurrence of infections, recurrence of staph infections, fungal infections. Those occur even out of the context of getting treated or not. We are dealing with live pathogens that are smart and are changing as we, put them under pressure from treatments, from vaccines. And so the key thing is we know that rebound is associated with people who have a lot of underlying conditions, and those are the ones that need treatment. And if the risk of not dying from COVID with someone with an older underlying condition is about 70-80%, but the risk of rebound anywhere potentially between 5 to 20%, what would you risk? Being infectious for a longer period of time, or potentially ending up in the hospital, or even dying from COVID? And I think balancing rebound with the benefits. We hear about messaging in the media about the risk of rebound, not as much balanced with the benefit of what will happen in spite of you taking in spite of getting the antiviral. If you really have these underlying conditions, will you still survive? What are your odds of surviving COVID? And allowing people to make maybe a more educated decision, rebound versus hospitalization or death. So.
Mm-hmm. Thank
Even
you.
to kind of piggyback off of what Artie stated, I will also say that we have to be vigilant about telling the patients, please take this for the entire time that it's prescribed and the way that it's prescribed. So I think this is, a big place for not only journalists to emphasize, to the patient, but also when writing, to emphasize that it's also the responsibility of the provider, whether it be the physician, whether it be the pharmacist, whether it be the nurse practitioner. When you are given a prescription for this drug, we have to tell people, take it exactly the way it's prescribed for the duration that it's prescribed. Because what we've seen from other publications that have actually looked at the in vitro, so taking it, from the benchtop, doing that really essential in the cell research to the patient, when they looked at it on the benchtop, what they saw was, it wasn't that the drug wasn't able to decrease the amount of the virus that existed in these individuals. And they saw that, these individuals that had a rebound, they indeedingly were able to form antibodies as well. The issue may have been that these individuals aren't exposed to the drug for a long enough period of time, meaning that these folks, may not be taking them for as long as it's prescribed. And sometimes when we feel better, we say, okay, we'll put that drug to the side and we'll go on about our lives. So I think we also have to be very serious, and we really need to emphasize that message. We really need to make sure we tell people, don't stop taking it when you feel better.
Thank you. And you can take this, or we can open it up to anyone on the panel. But just as you hear about rebound from patients, from providers, I know that there are some concerns over the interactions with other drugs. I wonder if any of you would like to talk about that a bit.
I guess I can start, and I'm sure that, if anybody else has anything else to add. So, Paxlovid is, we do see a lot of interactions with it. When we think about these drugs, so like Normotrelvir, which is, these types of agents are similar to what we may have seen, with the HIV protease inhibitor agents. And when we think about them, we think about the fact that they have a lot of interactions. And that's because these drugs are metabolized, or the way that they're degraded is through our liver, and our liver controls a lot of things in our bodies. So I think the point of solace that I have is that the one thing that we can do when we have these patients that are coming, or one thing that we can publicize, is that if you are someone that if you suspect that you may have COVID, if you can keep a detailed list of the medications that you take, I think that can speed up the process of being able to identify whether you're an ideal candidate for Paxlovid. And the great thing is that we do have alternative options, which in the real world we are seeing work well, that can be utilized in the event that these people do have a drug that may interact, with Paxlovid, and make it so that, and prevent them or preclude them from taking it. But if we can get comprehensive medication lists, then that makes, the decision processes a little bit easier. So maybe this prompts folks to think about, let me make sure I have at least the medications I take daily with me in a way that's accessible. I think too, with Paxlovid, and we do also have tools that can assist providers in identifying which medications would interact with Paxlovid. And then sometimes, each interaction is not created equal. So it may be that the individual has to time when they're taking the Paxlovid. So maybe you take it before, you take your medications, or maybe you take it a few hours after you take certain medications. So don't think that if you are someone that takes, an extensive list. I myself, I work in an academic job. I take a slew of medications, but I myself, I make sure to keep a list to create ease. But don't let the fact that you may have medications that you take for existing illnesses prevent you from seeking or identifying whether Paxlovid is something that you can take.
Thank you. And Megan, I wonder if we could come back to you. Obviously, there has been, a lot of research now showing that antivirals, decrease hospitalization, decrease deaths. What are we seeing in terms of how antivirals impact the development of long COVID?
Right. So thanks for the question. Obviously, we know long COVID is happening. We know it's been well documented. There's some really good descriptions of that. What we don't have are robust randomized controlled trials as to whether the vaccines or the treatments, right? We're talking about the treatments here, but there have been retrospective analyses of both the vaccines and treatments that have shown that they trend towards really helping to mitigate long COVID symptoms, right? So not only preventing that hospitalization and preventing death during the acute phase of COVID-19, which is obviously very critical, but also providing additional benefit to mitigate potential long COVID symptoms. So again, there are some pretty good studies that show, again, both on the vaccine side, that can help having that up-to-date vaccination, and then also having treatment during that phase, that acute phase of the disease, can actually help to mitigate those. What we're still, and then we'll wait for the randomized trials, right, which are occurring now and getting started up. But again, there are different reports out there, right, and to what degree that these treatments are helping. But again, as a whole, if you look at the whole body of work out there, there does seem to be a positive trend where these medications are helping against those long COVID symptoms.
Thank you. And Alex, back to you for a minute. Obviously, misinformation, is a huge issue when we still see that related to COVID online. How do you handle, these when you come across them? When do you decide to address them? When do you not?
Well, the short answer is it's not just my decision, right? I mean, it's a decision, especially when we're covering something. It's a decision you make with your editors. It's a decision you make with your team to figure out whether we're going to cover something, how we're going to cover it, how we're going to kind of unpack the misinformation that's in there. And obviously, it's gotten all the more complex. I mean, I'm sure folks saw the back and forth that we had between CDC and FDA and the Florida Surgeon General. But even when it's not coming from, state officials, even when it's coming from people online or, in the media, not always it's intentional misinformation. I mean, you often hear about these people who are maybe weaponizing the misinformation to advance a specific gain, but you also hear about people who just genuinely are confused or unaware. I mean, we were talking a lot about rebound earlier. That's something where it is hard, especially when, the CDC did a great job. I want to say a couple of weeks ago, they put out some MMWRs as well as a press release, really trying to break down, hey, the rebound is not an issue we think should be preventing prescribers from prescribing Paxlovid. And then what you saw after that is a lot of people who still were confused as a result of the way that those results were presented, because the reality is that rebound is something that is still being studied. I mean, Pfizer still has a clinical trial that has yet to read out results of using retreatment of Paxlovid for high-risk people who get rebound. So it is still an evolving field, and it remains really complicated to answer questions that people have about these issues. It's not a reason that we shouldn't answer those questions. It's not a reason that we shouldn't be asking experts and drug makers and the federal government to help us sort through what we know and don't know. But I mean, part of the problem and part of the reality is that COVID-19 remains a very complex topic and a very new topic at a time when even old respiratory viruses like RSV, there's still plenty of things we don't know about that. So anyway, it's a complicated issue, and it's something that's going to take all of us to kind of really work together to try to address.
Thank you. And I want to stick with you for a second and then open this up to everyone else. What do you think are journalists or maybe even kind of the public more broadly are still missing about this, or perhaps misunderstanding? You talked about rebound a little bit and how complicated it is. I'm wondering, what you hear both from, doctors and medical professionals that you're interviewing, as well as, the regular folks, and where are the frustrations right now?
Yeah, I mean, there's a couple things. I think just one recent thing that comes to mind, and we talked a little bit about it at the beginning, but I just want to kind of hammer it home, is that I think people don't quite understand how COVID-19 trends are being tracked right now. There's a lot of people who see, for example, wastewater is a classic one. People love the idea of wastewater. I love the idea of wastewater. It's a great way to get trends of how things are increasing and decreasing. But then you try to take wastewater trends and you put it in an article, and it starts getting complicated, because when wastewater is going up, what does it mean that it's going up? There's a great CDC explanation on their website of how they interpret the wastewater levels going up and down and the trends and the baseline. And, but unless you have a degree in, trying to make sense of that math, you're not going to be able to do a great job really understanding what it means when it goes up. COVID-19 trends that are measured through emergency departments are another great way that journalists and the public can keep track of how COVID-19 is spreading around the country. But the important thing about this, like all the other COVID-19 indicators, is that even when things are going up or down nationwide, that doesn't mean that they're going up or down in Illinois or Arkansas or Louisiana. And then even when you go to the state level, sometimes the trends in one health service area, that's a fancy way of saying a bunch of counties that are kind of related to each other, could be very different than another thing. You know, what the emergency rooms that I live near here in Arlington next to DC are seeing from flu and RSV and COVID could be very different than what the emergency rooms are seeing in Florida or in California. And trying to piece together a cohesive story about all these moving parts is something that I think often is hard, and it can be very easy just to say things are going up or going down, when actually what I think people really want to know is, what are things looking like in my area? And to the federal government's credit, they've done a great job standing up all of these resources to try to track this on a more local level, the state, the region, the local. But it's a complicated picture, and it takes some efforts to really go to the CDC's website and put things in context of where you are and when you are with that data.
Thank you. And to the rest of our panelists, what are you seeing, still being kind of missed by the media or misinterpreted?
Yeah, I'll just say two things from my vantage point that I want to highlight. One, we already talked about, which is essentially, we hear a lot from prescribing when we get to the hesitation part of things, and then sort of the myth busters, if you will. The two top ones we're hearing right now are, one, COVID's not that bad, so I don't need to worry about it, right? And that's from both the medical community and from the general public. And we heard it is still bad, unfortunately. It is so much better than it was. And in no small part because of all these medical countermeasures that we're talking about, effective vaccines, effective treatments, but it is still bad. I mean, 1,500 deaths a week, which is where we have been hovering in December, is not acceptable, right? That we need to do more to help those that are vulnerable. So that's number one. I think we just need to stress in the media and elsewhere that this is still causing hospitalization, causing illness, and causing death, and use every tool at your disposal to prevent that. The second one that we hear a lot, recently, and we've heard it all along, but it's now sort of drifted to the top, is my patient isn't sick enough, right? Come back when you're sicker. Come back, you don't need treatment yet. Come back when you're feeling worse. We know from decades of research, even beyond COVID, right, that antivirals, when they're given early, they work most effectively. If you wait too long, you've missed your window, right? We know, of course, that, we already heard one case where somebody went when they were outside of that 5-day window. You really do want to take these at first symptom. So what I would like to see the education more around, know if you're at risk before you get COVID, right? Make that determination with your physician, or, going yourself and being proactive on the CDC web pages or elsewhere, and really understand, am I high risk? Because that is the determination of whether you need these medications or not how sick do I feel, right? That is almost, now you're really, in most cases, too late for those to be as effective as they can be. So those are the two big things on my radar.
Thank you.
I'll just piggyback a little bit off that, because I think that's one thing I've heard a lot of, just a lack of awareness by providers too on what constitutes medical risk, and mental depression is a risk factor for complication of COVID, physical inactivity. And people, which would literally qualify most of the US population as having a risk factor for COVID. Now, those might morph over time, but those are still really subtle risk factors that people may not be aware of. And I feel they think heart disease, big picture, I don't have asthma, so I'm not at risk for COVID, but they don't realize that, I have some mental health disorder, substance use disorders, and that would put me at an increased risk for complications. So the other aspect that I think I would like to focus on is that this is an example when the real world studies came out around Paxlovid, the first big media headlines were Paxlovid doesn't work as well as we think it does. It's only 37% effective. And that was a big headline. But when you deconstruct that actual study, how researchers sometimes do, they pool the risk of hospitalization and death. And so that would say about 37%. But when you unpacked that, the risk of just not dying if you took either Paxlovid or molnupiravir was 84% or 77%. That is huge. And that message completely got lost. If you tell me you have a risk factor, this drug will be 84% effective in preventing you from dying, that's a very different headline than it's only it doesn't work as well, because that's the message people read. And unfortunately, communities that are disadvantaged, that may not have high literacy for, say, health literacy and, technical scientific literacy, and might latch on to some of the negative messaging. So perhaps I think what would be great to see a little more balance and deconstruction of what's really being presented in these scientific articles, which are very hard to interpret. I 100% get.
And as any journalist knows, the number of folks who go deeper than the headline is frightfully low. And so, yes, the accuracy in that area is incredibly important. Jacinda.
Yeah, so I think that I would tie both of these points together. I think that what was stated previously is just so important. For one, I think that the conversation needs to become that COVID-19 is still with us. I think I saw one headline and I was so excited to see it because it really emphasizes that, we'll see COVID-19 for at least the next decade. Like, we need to treat this as a virus that, we have come to expect, that we come to know and recognize is going to persist and consistently be something that we see. So I think that really emphasizing that, really urging people to continue to take this virus seriously, as Dr. Panini said, 1,500 people dying, from COVID-19. That's something that we should not tolerate. 3,000 people being infected per week nationwide, like that's unbelievable to me. To continue to see this virus permeate through, while we have these really effective treatments, I think that, we need to do our part in ensuring that people are aware of how serious this virus continues to be, especially for those people that are disparaged. I think that, that really needs to be a part of the conversation. And then one thing that I would also say is really emphasizing and discussing how is it that the landscape of healthcare looks different now that we have commercialized these products. So I think really talking about, that provider experience. For me, I have had a terrible experience getting preventative therapeutics for the vulnerable community that I serve. So I think telling those stories and saying, COVID-19 is still here, is still a problem. And then in vulnerable communities, we're seeing a complete cessation of tools that we've previously used to really mitigate this pandemic. And then an additional thing that I would say, or I would discuss, is, the ideas that we may have had pertaining to hesitancy, pertaining to a lack of uptake concerning these therapeutics, the thoughts that we had at the initial start of the pandemic, they are evolving, but we also need to evolve in the way that we express and we describe these communities. And then I think that I would wrap up in saying, and I think it was a really good point that Artie made, and I'm losing it. So I'm trying to remember exactly what I want to state there. How it is that we portray the numbers, how it is that we talk about, the way that these therapeutics work, and the way that we position the narrative. I think that really needs to be something that we emphasize, because and when we think about the Pew Research data, more than 80% of racially and ethnically minoritized individuals receive their medical information from the media. So if someone from a minoritized group reads that headline, and we know the structural racism and structural disparities and biases that exist that really put them at a disadvantage for health literacy, well, now we're in this place to where they're thinking, well, I'm not going to get this treatment. I'm more likely to get rebound. Nobody really explains what rebound is. So it's like, I'm more likely to be, sicker than I were previously. I'm not going to pursue the treatment. So I think, you know, flipping that context and thinking about who it is that's going to be more likely to consume this information and only run with that minimal data that's provided at that headline, that can really change the way that I feel we move forward in portraying the pandemic.
And thank you for emphasizing the journalist's huge responsibility in that area particularly. And I also want to thank all of the panelists for answering. We did have a number of questions come in sort of in the last few minutes, and thank you for answering those in the Q&A. I also want to just assure all of the participants and the folks who've been tuning in that the links of every study that's been mentioned and answers to all of the questions will be posted when National Press Foundation does a recap of this session, which will be made available on nationalpress.org, as well as shared in our newsletter. So please, you know, don't worry. We will make sure that you have this recording and all of the resources that you need to do great reporting on this topic. I want to thank all of the panelists. This has been a wonderful conversation, and I really appreciate the expertise that you bring to this and the time that you've taken. And thank you again to our sponsor, the COVID-19 Vaccine Education and Equity Project. And we wish you all good health moving forward in this season. So thank you again for joining us. And again, you can find all of this information at nationalpress.org. Thank you.